Totally cool. I just want to start off by saying thank you both for being here. My name is Mia. I don't know if you are familiar with Alyssa, who normally teaches these grounds, but she's one of my colleagues and she's on a trip right now, so I'm filling in for her. But I have done one of these or a few of these grounds before, so um, you might have seen me before, but if not, I'm Mia. I work at Girls Love to Fly, but also Mach 5 Aviation up in Auburn. So yeah. Let me go ahead and share my screen with you, and then if I could get one or both of you guys to give me a thumbs up that you can see it, that would be wonderful. Okay, cool. All right. Let's see.
Can
All
see the screen.
righty. You can see it? Wonderful. Okay. All right. So we're going to be talking about aeromedical factors today. Aeromedical factors is kind of a big topic area, in all honesty. If any of you are familiar with the ACS, the Airman Certification Standards, it's basically aeromedical factors takes up a whole page on its own. So I wanted to include some of the more pertinent and aviation specific medical factors today, and kind of give them their light of day, without, kind of covering things that are a little bit more commonly talked about, such as fatigue and stress, nutrition, dehydration. Um, so the agenda for today is going to be hypoxia, middle ear and sinus, vision and visual illusions. So all of these are kind of hefty subject areas. I don't know what all of your familiarity is with any or all of these. So I'm going to kind of go as in depth as possible, but if I'm not explaining something adequately, please let me know if you have questions at any point. I can't super see Zoom, so you can just unmute and interrupt me. That's totally fine. But we will have more discussion at the end as well. All right. So we're going to get into hypoxia first, which I honestly think is one of the bigger talked about topics for aeromedical factors, being that it is pretty specific to aviation. Um, so hypoxia as a whole is defined as the lack of sufficient oxygen in the blood, tissues, or cells. So you can kind of think about it as lack of oxygen in the body as a whole. Now, there are four different types of hypoxia, and we're going to get into all four of them and talk about, how they occur, um, where they occur. They all affect you the same way, just for clarification. No matter which four of the hypoxias you're experiencing, they're going to have the same symptoms and the same treatment. So, but it's important to distinguish them from each other to know how to avoid them, and then also kind of know how to diagnose them based off of context clues. So we're going to start with hypoxic hypoxia. Um, Hypoxic hypoxia is the most common form of hypoxia in aviation. It is defined as lack of oxygen in the lungs. This results from lack of oxygen in the atmosphere. So it's typically altitude induced hypoxia. If you are traveling, usually above 10,000 feet, MSL, you're going to start entering, you know, lower density air. And what that means, lower density air, is that the air molecules and thereby oxygen molecules are more widely dispersed. So when you're breathing, your lungs have to kind of work a little bit on overdrive in order to intake the same amount of oxygen they would at, per se, sea level or at McClellan or wherever you're from. We kind of live, closer to sea level than, most. So um, it's I'm sure that at some point you have experienced taking a hike or taking a drive up to a higher elevation, and potentially feeling a little bit breathless, a little bit dizzy, nauseous even. That's because you're likely experiencing a level of hypoxic hypoxia. Um, so what is happening is, your brain and your lungs, your whole body needs oxygen in order to function. If there's insufficient oxygen in the atmosphere around you, well, no matter how hard your lungs try, they're not going to be able to intake enough oxygen in order to sufficiently power your system. So this can be felt at lower altitudes as well, and we'll get more into that. But hypoxic hypoxia specifically affects different people in different ways. So, for example, someone may start to experience hypoxic hypoxia at 8,000 feet, while another person of, seemingly the same build, gender, age may experience it at 14,000 feet. But you as a pilot and also as a passenger at some point need to be aware of your own, I guess, response to hypoxia and when you're going to be most susceptible to it. So, that being said, we'll move on to hypemic hypoxia. Do you guys have any questions about hypoxic hypoxia? We're going to circle back to it at the end just because it's kind of the biggest one. No? Okay, cool. So hypemic
I
hypoxia.
don't have any questions either.
Okay, awesome. Thank you. Um, Hypemic hypoxia is lack of oxygen in the blood. And I also want to notate that I try to tie these all into like lack of oxygen because they ultimately they are. It's just where the oxygen is lacking. So if you can kind of remember them in that commonality, lack of oxygen in the blood, lack of oxygen in the lungs, it makes it a little bit easier. Like they have this thread of commonality. So hypemic hypoxia is lack of oxygen in the blood. Now, you may notice that the word hypemic sounds kind of like the word anemic, and that is because it works very similarly. So there is sufficient oxygen in the atmosphere. Your lungs are able to intake sufficient oxygen. However, your blood cells essentially are not able to receive it. So the reason that that's happening could be a few things. The most common are going to be anemia, as we talked about. Sulfa drugs, which if any of you are unfamiliar with what a sulfa drug is, it is a type of like usually a type of antibiotic. So if you are like on any type of antibiotic that may have sulfa in it, that chemical will bond to your blood, your red blood cells, and prevent the bondage of oxygen. But also carbon monoxide poisoning. That's a big one. So CO2 bonds to your blood at a rate almost 3 times as quickly as oxygen can. So when that happens, obviously, once you start experiencing carbon monoxide poisoning, the oxygen is no longer able to form that bond with your blood. So even though the oxygen is sufficient and available in the air, the body essentially and the blood specifically cannot receive it. So that this is, more concerning because as you can kind of start to come to conclusion, we're going to talk more about treatments on the next page, but just to prelude that, you can think of hypoxic hypoxia. You're like, okay, well, I'm at a high altitude, there's not sufficient oxygen up here. What's the common, what's the first thing I could do? Well, I could descend, right? Well, hypemic hypoxia has nothing to do with the available oxygen. It has to do with your body's ability to accept it. So that's a little bit trickier. And we'll talk more about how to treat that on the next page. But yeah, that's hypemic hypoxia. Histotoxic hypoxia, kind of remember this as being like when you think about toxic, think about drug, alcohol, because histotoxic hypoxia is lack of oxygen in the cells. So, and not to be confused with the blood cells, it's more to do with actually your brain cells and your brain's ability to accept this oxygen. So there's oxygen in the air and it's able to bond to your blood cells because you're not experiencing hypoxic or hypemic. However, it cannot be utilized by the brain. The reason for that is because, um, as you know, a lot of drugs and alcohol are depressants or stimulants, depending. But because of that, they form a bond with your brain cells, the receptors, preventing your oxygen from being received as efficiently from the blood. So actually, when you think about it, and it's kind of a like I don't know, kind of an interesting fact that I didn't really think about prior to becoming a pilot is, or make that connection with, is you're actually experiencing histotoxic hypoxia every time you're under the influence of anything. Like if you've had one beer, two beers, you're experiencing histotoxic hypoxia. A glass of wine, you are hypoxic essentially. Now, histotoxic hypoxia, I would say, is the most common form of hypoxia outside of aviation for that reason. Um, I would also say that um, it's kind of viewed as being the least lethal because in reality your blood and your lungs are still functioning with the oxygen, therefore like it's being circulated to your heart and your lungs and to some extent your brain, unless you like get alcohol poisoning and die, which would take quite a bit. So histotoxic hypoxia is a little less lethal because there still is oxygen in your system. It just can't be utilized effectively by the brain. So yeah, any questions about hypemic or histotoxic? Okay, cool. So our last one does not start with an H. I thought it would be kind of nice if they all started with H's, but they couldn't be like that. And that is stagnant hypoxia. You've also definitely experienced this at some point. It's lack of oxygen in the tissues. What does that mean? Well, like your muscle tissues. So if you've ever, sat in the wrong position for too long and your foot falls asleep, that's stagnant hypoxia. Um, there's blood in the air. I'm sorry, there's oxygen in the air, in the blood. However, it cannot properly circulate to deliver it to the tissue, right? So say you're sitting on your ankle or something, right? You're restricting the blood flow there, causing that limb or that ligament to become stagnant hypoxic. Um, Now, in terms of aviation, it's like, okay, well, sitting on my limb for a little bit too long isn't going to cause me too much harm unless it goes on for, days at a time. But what we experience in aviation, maybe not you and I, but like fighter pilots, is pulling excessive G's. So, if anybody's unfamiliar with the term of like pulling G's, it essentially means putting yourself in a positive or a negative gravity state, increasing the weight felt upon you based on the aircraft's configuration. So it's like if you're pulling 2 G's, your body weighs twice what it would normally, 3 G's, 4 G's, 5 G's, so on, right? So, and fighter pilots pull 7, 8, Oh, sorry guys, I don't know what happened there. It seems like I lost you. Can you hear me all right now?
I can hear you now. I don't know about anyone else.
Yes, I can hear.
Okay, I'm so sorry about that. I don't know what happened. My Zoom window just like crashed for a second.
I can hear as well now.
Okay, wonderful. Where did I lose you?
You were talking about the G-force for the pilots. That's where I couldn't hear
Okay.
anything. I don't know about anyone else.
Yeah, I think you said they pull 7 Gs, and it was sometime right after.
Okay. Okay, cool. I was worried that maybe I lost you like a super long time ago. Okay, cool. Sorry about that. I'll just kind of rehash stagnant hypoxia real quick. So, yes, it happens when the fighter pilots are pulling Gs, 7, 8, 9 Gs. Their blood in their body becomes 7, 8, 9 times heavier than it actually weighs. And so what happens is it gets coagulated kind of in the bottom ligament, so like the legs, the feet. Um, and what that causes as well is for all that blood to be diverted from the brain. So what can ultimately happen is that pilot would gray out or become unconscious. And obviously, in a high intensity maneuver, you don't want to be unconscious. Our Air Force has and Navy has come up with the G suit, which helps the pilots, regulate that and prevent stagnant hypoxia from occurring. However, the other thing that they can do is the same thing you would do like if your foot was asleep, right? Is if your foot's asleep, you got to move it around, get the blood back circulating. So that's the same thing that the pilots do is they will, clench or move or isolate like, their fingers or toes, their knees to try and get the blood, to still properly circulate in their system. So, yeah, just to recap, hypoxia is lack of oxygen in the lungs. So it's primarily altitude induced. Hypemic hypoxia is lack of oxygen in the blood. So there's a blood inhibitor, such as anemia, right? Which has blood deficiency, iron deficiency in the blood, carbon monoxide, which is CO2 bonding to that blood instead of oxygen. Histotoxic hypoxia is lack of oxygen in the cells. So oxygen is present in the atmosphere, so the lungs and the blood, but can't be utilized. And that's caused by drugs and alcohol. And then stagnant hypoxia is lack of oxygen in the tissues, which is, um, you know, lack of circulation. Essentially, the blood cannot flow to deliver the oxygen to some part of your body. Do you have any questions, any comments, any concerns before I move on to symptoms and treatment of hypoxia? All right. Let's see. Kind of let this little thing out of the way. All righty. So now we've talked about the 4 types of hypoxia. You probably want to know, okay, how am I going to figure out if I or one of my passengers is experiencing hypoxia? And if they are, how am I going to treat it? So, like I said previously, all 4 types of hypoxia are going to have very, very similar symptoms and signs. So it's not like you have to remember different symptoms for different types of hypoxia. It's all the same. However, as I have a little note down here saying, everyone has unique symptoms and signs when being affected by hypoxia. I don't know if any of you are familiar with or have heard of kind of like the hypoxia simulator. They'll put you in kind of a controlled environment and purposely make you hypoxic in order to evaluate your symptoms and signs so that you'll know how to assess them in yourself. So if there's one of those chambers or simulators at Beale Air Force Base that they do allow to the public. So if you have you have the opportunity to go utilize that, I would highly, highly recommend it because I think a lot of people underestimate just how like truly deadly, honestly, that hypoxia can be, especially like in a single pilot operation situation. So let's know about the common symptoms and signs. So they will kind of increase in, I guess, severity as time goes on. So It will start with an increased rate of breathing, because your body is being deprived of oxygen, a headache, lightheadedness, dizziness, tingling or warm sensations in the body, poor coordination, impaired judgment, tunnel vision, and euphoria. Sometimes also cyanosis can result. If you're not familiar with what cyanosis is, it is blue tinging of the lips and fingers. However, that's a pretty severe sign. Like you're already having a lot of other issues at that point if you're experiencing cyanosis. There are audio recordings of pilots who are experiencing hypoxia, and it's very clearly like they think that they are sounding rational and coherent, but they quite literally sound like they're drunk. Like their speech is slurred, their reactions are very slowed, and a lot of the time it's but like when the person realizes it of themselves, it's already too late. So it's very important to have those symptoms that you know of yourself, like kind of on, on the ready. Being able to diagnose them quickly and treat them effectively is going to be super important. However, also being able to see them in your passengers and kind of anticipate that is very important. So a good way to analyze whether or not your passenger is experiencing hypoxia or may just be having a headache or or in the case of increased rate of breathing may actually be hyperventilating, is when you become hypoxic, along with that poor coordination, tunnel vision situation, your ability to solve very basic problems goes absolutely by the wayside. Again, there's another video of people who are purposely made hypoxic and they're being asked very simple math equations or very simple memory items, and they like very clearly think that they're killing it. They're like, oh, I got this, right? And they appear, I mean, sloshed, like absolutely drunk. They're not making any coherent sense. And that can result after just 3, 4, 5 minutes of being extremely hypoxic. So you can ask your passenger like a very basic math question, right? Like, oh, what's 2 times 8, right? Or 4 times 8. And just kind of gauging their response on that is going to give you a really good idea of, how well their brain is functioning. And give you an idea of, okay, is this person experiencing hypoxia or not? So now that we've talked about symptoms and signs, let's get to the most important part, which is treatment. So hypoxia can be very deadly. Obviously, as you would imagine, your body needs oxygen to survive, function. So lack of oxygen or complete deprivation of oxygen can absolutely be fatal. So the first and foremost thing to be aware of with hypoxia is to familiarize yourself with it and symptoms and signs, but also to familiarize yourself with any type of pressurization or oxygen system you have on board your aircraft. And now, if you all are flying out of Girls Love to Fly or, working on your private instrument commercial, CFI, one of those ratings, you're probably not flying a plane with pressurization or oxygen. And if you are, kudos. But this is probably not something that you are familiarized with day to day. However, regardless of what your goals may be as a pilot, at some point you probably will come into counter with a oxygen system of some sort or even a pressurization system. So knowing what you have on board, if you have anything on board, is very important, and knowing how to utilize it. So if your passenger is experiencing hypoxia or you're experiencing it yourself, it's important to pretty much immediately administer supplemental oxygen. We'll talk about the different types of supplemental oxygen or some of the more common ones in a minute. But if you suspect hypoxia, you should be proactive rather than, I guess, giving it the benefit of the doubt. In the situation of hypoxia especially, which again is the most common one, It's super important to get that person breathing, sufficient air molecules, getting those lungs filled up, getting that circulated to the brain. In the case of hypemic hypoxia, where there potentially may be, carbon monoxide bonding to the system instead of oxygen. Unfortunately, you can't really get the CO2 to unbond from the blood. However, it's super important to remove whatever CO2 they may be breathing. So giving them that supplemental oxygen will ensure that they're still breathing, clean air, although treating carbon monoxide is its own emergency situation, which we can talk about as well if you'd like to kind of at the end. But nonetheless, treating hypemic hypoxia in that way is very useful as well. So knowing how to administer the supplemental oxygen, knowing how it works, if the person is receiving it correctly, and in turn with that, monitor the breathing rate and depth. So if any of you have ever been like scuba diving, or even experienced somebody having like a panic attack, that when those rapid breaths start occurring, it's not only inefficient for truly filling the lungs and receiving adequate oxygen, but may actually turn into a hyperventilation situation where you're now receiving too much oxygen. So monitoring your breathing, taking deep, steady breaths of the oxygen is going to be very important to getting the results you're looking for. As we talked about before with hypoxic hypoxia, if you have the capability of descend. Now, if there's like terrain, and that's the reason that you're up at that altitude, and you don't have the possibility to descend, definitely administer that supplemental oxygen and potentially alert air traffic control, like en route control, that you may need medical assistance at your destination, or even make a diversion depending on how severely your passenger or yourself are experiencing those symptoms. But the biggest thing is really to just be proactive. Don't put yourself in a situation where you might be susceptible to hypoxia without a cure. If you have to fly for a long period of time over high terrain, it would be very smart to bring supplemental oxygen with you, or, to know your symptoms. And if you, like, for example, if you are taking passengers, know whether or not they have, drank in the previous 8 hours, or if they have any conditions such as anemia. Just knowing that information about yourself and others is going to pretty much avoid you having to even be in this situation in the first place. But lastly, we'll talk about some of the more common types of oxygen systems very briefly, because again, this could kind of be its own separate deal, but in the vein of treating hypoxia, you should probably know how you can do that. So on the far right here, I have an oxygen monitor, which I would definitely recommend, like, as once you are, or if you are already a certificated pilot, to have one of those in your flight bag, especially if you do cross countries at all, just, kind of to check in with yourself, your passengers, see where your oxygen level is at. That will give you a good gauge and not wait until symptoms start to appear. Right here is something called a cannula. Cannula is going to be the most common type of general aviation oxygen. It's typically continuous flow, which means that, once you turn on that valve, it's just gonna keep flowing. It goes into your nostrils, and typically is stored in like a canister in the back, or in like above the heads of the pilots. So knowing how to operate this, knowing how to service it, how to ensure that the oxygen is the correct type of oxygen, if you have that system on board, is very important. I highly recommend, if you ever get in an aircraft that has an oxygen system, even if it's just like a 182, a 172, something you're comfortable with, I would definitely recommend getting a checkout specifically on how to administer and use the oxygen in there. And then, yeah, lastly here, we have the oxygen masks, which are less common in general aviation just because they're a little bit more expensive and kind of tedious to maintain. But they're going to be like demand flow, so kind of similar to scuba diving. It's just going to be when you're breathing in and out. They're a little bit more effective, a little bit more conservative when it comes to the oxygen, but definitely less common. So just knowing the type of oxygen systems that are out there, knowing if your plane has any, but also knowing that there are portable options. Like you can buy a little canister of breathing oxygen, aviators breathing oxygen to bring with you on a flight, so if you're doing a cross-country flight or a high altitude flight and you just want to be extra careful, which I would definitely recommend, just snag yourself a little $30 bottle of oxygen and bring it with you just in case, anything happens and you don't want to be up there and be unprepared. So yeah, that is hypoxia, kind of the rundown. Any questions? All right. Okay. Next, we're going to talk about the middle ear and the sinus, which I think is kind of funny because if you guys can hear it all, you can hear that I kind of sound a little congested, and I am. So, it's kind of a funny topic for me to be writing about, but firsthand experience. So, before we talk about kind of the aeromedical factor side of this, we're going to talk about the composition of the inner ear and of the sinus. So just so you get kind of an understanding of how the system works and the pitfalls there. So there's something inside of your inner ear. Well, it's really in your middle ear between your skull and your middle ear called the eustachian tube. The eustachian tube is responsible for allowing the ear to equalize pressure. It's kind of like the release valve in there. If you've ever yawned, which I know you have, you've yawned when you've gone up in elevation, you kind of feel your ears pop. That's the eustachian tube opening or closing, kind of like a little release valve. Because you can kind of think about our inner ear like a soda can or a chip bag or something else that has sealed pressure in it. If it's all sealed away in there, it's all good when we're at an equilibrium atmospheric pressure. However, when we change atmospheric pressure, such as ascending or descending, that chip bag or the soda can is going to compress or expand. So if our eustachian tube cannot allow us to equalize, then our inner ear is going to act the same way. Inside of the sinuses, there is it's actually in between the sinuses and the nasal passage, your nose there. There's also a small opening that serves the same purpose as the eustachian tube in the ear, and it is also responsible for equalizing your sinuses. The sinuses also are more directly related to your head. So just because, as you know, like your nose is kind of connected to your brain. So if you can't equalize your sinuses in a way, you're actually experiencing trapped gas in your head as well, which is no fun. Two things to know here. I'm not going to get too deep into the composition of the inner ear just because that has to do a little bit more with kind of the bodily illusions, the leans and the acceleration and all that stuff. And again, that could kind of be its own discussion. But if you're familiar, you know that they have our little cochlear, which is our little like inner ear onion. It looks like a little onion in there. It's responsible for our balance, coordination and spatial orientation. If any of you are instrument students or are instrument rated, you know that this has a big, big role in maintaining our spatial orientation and situational awareness. So noticeably, if your ears are clogged, right, your eustachian tube cannot equalize, then these environmental factors that allow us to use that inner ear for balance, coordination, and orientation are, they're interfered with. So if you have like a clogged ear, you may feel yourself becoming more motion sick more easily, feel dizzy, nauseous, off balance. And that all has to do with that inner vestibular system. That's what it's called, the vestibular system. Now the sinuses, like I said before, those are responsible for equalizing the head and sometimes even the lungs. So, again, I'm not sure if any of you have ever been scuba diving or even snorkeling, or even just swam with, like a sinus infection or being congested. But, when you feel like when you dive down under the water, that pressure that just fills your head kind of behind your ears, in your entire face, essentially, that's all your sinuses. So they're responsible for quite a lot going on in there. So it's no fun if that's all clogged up. So let's talk about how that relates to trapped gas. I know I kind of did a little bit, but think about your body kind of being like, like that soda can. We need to be equalized in pressure to our surrounding atmosphere. So you can even think about it in the sense of like a submarine or an airplane. As the submarine goes down under the water, right, there is a much higher pressure outside of that vessel than inside of it. So it's being pushed in on, right? If there was ever a puncture to that vessel, it would implode, right? Implode. It would, shrink in on itself. So, put that in the context of your ears, right? Okay. Now we have an airplane, right? And the airplane is sealed at, 8,000 feet, right? It goes up to 36,000 feet. Well, now we are the higher pressure, right? There's a higher pressure in the cabin, trying to push outwards into the lower surrounding pressure in the atmosphere. So if there were to be a puncture, well, we'd explode, right? Go outwards. So again, think about that in the context of your ear, in the context of your sinuses. And when this comes into play is when you think, oh no, I'm just a little congested. I just have a little bit of a snivelly nose. It's okay. I can go fly. Well, no, because now you're turning into the airplane, or worse, the submarine. You're like, well, I'm not descending. How am I turning into the submarine? Well, there is, something you should know is that it's a lot easier for the body to re-equalize in an ascent. So when you are the higher pressure, right, than in a descent. So like the submarine has a harder time than the plane. The reason for that is because when there's higher pressure inside your ear, it's kind of trying to push outwards and crack that seal anyway. Versus when there's higher pressure outside, it's shriveling in essentially, kind of acting like an implosion moment. It's harder to get your body to naturally equalize that. So what can often occur is you think, oh, I'm good, I'm fine, I'm not that congested, and you ascend up to 8,000 feet and you're fine, you feel your ears popping a little bit, but now you have to come back down. And that's where it's going to get you, is because now your ears are going to have, or your sinuses are going to have a lot harder time equalizing, because now you're the submarine. And so sometimes what can happen is that, your eardrums will, actually, burst, or your nose will, like the blood vessels in your nose will burst, or worse, worse, but also terrible in its own right. It's just you're going to be in a lot of pain. And you don't realize that on the ascent because, again, it's easier for your body to equalize, but now on the descent, it's catching up to you. So it's highly discouraged to fly with any congestion or sinus infection. Again, I like to relate this back to scuba diving. You don't want to be in a pressure differential situation and your body won't equalize, because you don't want to be the submarine. You don't want to be the airplane, right? Because eventually something will puncture, and that's going to be your ears or your nose or something, and that's going to hurt you a lot because your body has to equalize. You don't want to force it to do that. Now, it's not only your ears and sinus that trapped gas can occur. It can also occur in your teeth and your G tract, which is your intestinal area. Tooth is more so because, again, it's in like that head region. So you can actually start to feel really intense pressure in your teeth if you're having a trapped gas situation. And then in your G tract. So if you have trapped gas inside of your stomach, inside of your intestines, that, that's going to be extremely uncomfortable as well. So, kind of biggest takeaway there is if you sound like me and you sound congested and, a little sniffly, don't fly, because, and it's, like I said, you don't want to be submarine, you don't want to be the plane. Now, there are things you can do to equalize. I'm sure you know, like I said, you can yawn, you can dry swallow, sometimes helps people, move your jaw around. The Valsalva maneuver, where you kind of grab your nose and blow outwards, can sometimes help. However, that has also blown people's eardrums before. So, I do with that what you will. But, if you're noticing you have to do those things on the ground, you definitely don't want to put yourself in a situation where you might not be able to do it in the air. And if you think like I've met people who this has happened to, not a fun experience. So yeah, that is the middle ear and the sinus. Do you have any questions about that?
Does the air getting trapped in the tooth just happen when you've got like a sinus infection or something, or it can be random?
No, yeah. So, good question. Yeah, it's directly related to a like sinus infection or a extreme congestion. So it will equalize kind of from that nasal area down into the top row of your teeth.
Wow, good to know. I
I
never
know,
heard
yeah.
that.
I didn't know that either. Like that, until I got my CFI and I was like, oh my goodness gracious, that sounds miserable. So, um, just again, it's kind of all a situation of like, just don't end up in this situation. Same thing with hypoxia. If you know the symptoms, the signs, if you know how to prevent it, prevent it. Don't end up where you have to solve it in the air because, you could end up hurting yourself or just having a miserable time, and nobody wants that. All right. Let's see. Now we're going to talk about vision, kind of staying in the same general space. So vision is pretty much the most important thing that we have as pilots. Our orientation as pilots is pretty much 70% based off of vision, 20% vestibular, which is the ear system we talked about, and 10% kinesthetic, which is kind of like seat of the pants, so just the feeling of your body moving. So vision is obviously the most important one. But in order to understand it and make sure that it's there and working for you, you need to know how the eye works. So, disclaimer, I'm not an anatomy professor nor an anatomy specialist, so I'm trying to kind of give you a rundown of how these things can join together. But if it's not 100% like biologically accurate, I apologize. Just want to give you the rundown. So, we'll start with the start. So pretty much all viewing is based off of light. And so from when the light hits your eye, we'll just go from there to how you see. So it starts with the light hitting your cornea. The cornea is like the thin dome shape on the surface of your eye. It receives the light and it acts as a dome. Then the pupil and the iris decide the allowance of passage of some of this light to the lens. So the pupil is what receives some of the light, but the iris is what kind of meters it, so allows how much it would like to pass. They then allow this light into the lens. The lens is also kind of like this clear, gelatinous I guess, I don't know what word to use, clear gelatinous material behind the pupil and iris. And this receives that light and focuses it onto the retina. The retina is kind of where the magic happens. The retina transforms the light into electrical signals, and from there sends it to the optical nerve, and the optical nerves connect to your brain, obviously, and sends those electrical signals back to the brain to form images. And that's how you see. So it's just light, it's filtered in. It's it's not all allowed in, because if we let all the light in all the time, we would be blinded essentially all the time, flash banged. So it's filtered in. It's reflected via the lens onto the retina. The retina transforms it into electrical signals, and those electrical signals are sent via the optical nerve to the brain, and the brain, through all its magicness that it won't even pretend to understand how the brain works in such, eccentric ways, turns it into images. But the biggest thing to understand for you as a pilot is the light aspect, because with the light aspect comes our different types of visions. And this is where kind of the meat and the gravy is for a pilot, because we need to understand when our vision is optimal, where our blind spots are located, and what receptors are being used when there's different, lightings. So we'll start with photopic vision, which is what we're using most of the time. It's kind of our day vision viewing, or our highlight. So the light level high, that can either be direct light like from the sun, or it can be fluorescent light, like fake light in a room. Your viewing when through photopic vision is the center, so your center viewing, and the reason for that is because we have cones and rods. They're in the retina, and the cones are all, mostly centered in the center of the retina, whereas the rods are more dispersed around the side of the retina. And this will come into play when we talk about our different types of viewing. So we're viewing center because we're primarily using our cones, because there are light receptors. And our color perception during photopic vision is good. This is our best vision, is photopic vision. And which is good because that's what we're using most of the time. Then I'm actually going to skip the middle one and come back to it so we can kind of meet in the middle. But we're going to go to scotopic vision. The light level, oh no, the text didn't change. Okay. My apologies for that. The text on here didn't actually change, but I will tell it to you. So sorry about that. The light level for scotopic vision is low. The viewing is off-center, so it's peripheral viewing. The color perception is non-existent. Rods cannot actually see color. They can only see like shadows. And the receptors are our rods. So sorry about that. I think that it accidentally copied from photopic vision, but it's basically the opposite of photopic vision. It's our night viewing. At night, there's no light. So our cones are not effective because they are the light receivers. However, our rods are what give us our, they kind of see in black and white shades. However, we're going to have a center blind spot at night because, again, you think about those cones are all congested in the center. Well, they're pretty much useless when there's no light. So we have a center blind spot and must use peripheral off-center viewing in order to effectively, scan the environment and obtain a accurate picture. So we'll meet back in the middle at mesopic vision. Mesopic vision is medium light level. That's kind of during the dusk and the dawn. And you'd think, oh, maybe this is best of both worlds. It's not. It's worst of both worlds. This is when your eyes are at their least effective. You're viewing off-center and center, so peripheral and center, but that's because your cones and your rods are acting at their least effective. The cones don't have enough light in order to receive a proper image. However, rods, they do not like light. They don't function off of that. So they're being rendered, ineffective or less effective because of exposure to light at all. So you're kind of at your worst vision-wise. You're experiencing both your center and off-center blind spots during mesopic vision. Your color perception is some, like if you could think about, I don't know, flying around at sunset, the ground is cast in shadows, so you're kind of seeing more rod perception through there versus, like looking at the sunset, which you're still receiving light from that. You can have color perception. So that's why your color perception is some, and your receptors are cones and rods. So you just think about it. We've got day, we've got dusk, dawn, and we've got night. They all pretty much, it's kind of like a steady path of center viewing, both center and off center, and then off center viewing, and then going from day being primarily based on light and color perception to night primarily being based on shade perception, like shading perception. And then mesopic vision is the worst of the two. So not only is it rough to be flying directly into the sun if you've ever done sunrise or sunset flights, but you're also unfortunately at your least effective eye-wise. Do you guys have any questions about the vision types? I know I kind of went over it a little briefly, or how the eye works. Okay, I just want to make sure that I'm making sense. Sometimes I'm like, okay, I just want to make sure it's like, you guys are understanding. But if any questions arise at a later time, again, always feel free to ask. You can interrupt, I don't mind. Okay. And now we're going to talk about some of the visual illusions. So the visual illusions are, there's quite a few actually. And some of them are more to do with IFR flight, but I kind of try to make my grounds primarily for like the private commercial pilot, just because IFR is a little bit of its own world sometimes. So we're going to be talking about 4 of the primary VFR visual illusions. You may have heard of them before. We're going to talk about autokinesis first. Autokinesis is when a stationary light appears to be moving. If you've ever done a night flight and you are looking out at the stars and you're like, oh wait, is that a plane? Is that thing moving at me? Is it a satellite? That's autokinesis. And the reason for that is because you're staring at it. And as we know, what's primarily responsible for our night vision? Our rods. And what does our rods need? Off-center viewing. So if you're staring at it with your non-effective cones, well, your eyes are going to start kind of tripping out a little bit, and they're going to make it appear that that object is moving because you're hyper fixated on it. So night scanning, you primarily use your peripheral vision when night scanning, and it's very important not to focus on one particular object for more than about 8 seconds. Yes, okay. And then we've got false horizon. False horizon, it can result during the day or during the night. It results from an obscured or restricted horizon. So we'll just talk about the night example first. Is like, again, in the situation of stars, you think that you see, a perceived ridge line or some terrain because you think that you see the stars overlining it. But in actuality, maybe it is a city, that you're aligning yourself with, off in the distance. And you may set your aircraft into an unsafe position based on false visual cues. So how that works is, you sit there and you go, oh, well, that's my horizon. And if your horizon looks kind of slanted, you may perceive yourself to be in a bank angle, and so you may attempt to correct the attitude of your aircraft to align with this horizon. But if the horizon is false, then you've actually put yourself into a banked attitude or a nose low or nose high attitude. So This can also occur during the day due to like mountain obscuration or clouds or haze or fog or something of the sort. If you're flying over like a marine layer or a long stretch of like stratiform clouds, you don't have any visual reference to the ground or visual reference to any horizon points. You may think that, the clouds are your horizon. Oh, well, surely they're following the scope of the terrain. Well, no. And you accidentally align yourself with those clouds or with the haze or, whatever it is that you're looking at. And again, setting yourself into a, just not a straight and level attitude. And if that perpetuates, then it could potentially become unsafe. And the last one, or not the last one, I'm sorry. Well, the last one for night is the black hole illusion. Black hole illusion results when only the runway is visible. What that means is like you're kind of shooting this approach over featureless, non-detectable, non-discernible terrain. If you've ever like flown into like Chico before at night, which a lot of us I think do for our long cross countries at night, this can definitely happen. It's like this long lit runway and then just black, like dark ground surrounding it. This makes you think that you're higher than actual because you have no reference to the surrounding terrain and can sometimes result in an unsafe, unnaturally low approach. This also can occur over water, open water. So like if you're shooting an approach over open water, again, open water is actually, even during the day, can sometimes be featureless terrain and can give you this illusion, but especially at night, no discernible difference between the sky and the water at night, especially if it's a moonless night or a starless night, or overcast night, something like that. It's going to cause you to shoot that unnaturally, unsafe, low approach. So, really, with both of these, this horizon, the false horizon, and the black hole, your biggest resolution for this is to trust your instruments. Your eyes, as much as you love them, I love my eyes. They do lie to you sometimes. And so, you have to fall back on the trust of your instrumentation in order to ensure, no, okay, I am at my proper glide path, or no, I am at my proper altitude, or I am at my proper attitude or alignment with the horizon. So, and then lastly is reduced visibility. Reduced visibility is going to be still VFR conditions, but you're going to be flying in like fog or haze or smoke. I don't know if any of you ever have flown in any of these things. Smoke especially can be very unsuspecting. So you're flying along and it's a little smoky, and then boom, suddenly like you're like in 3 statute miles visibility and you're like, oh no, okay, what the heck? So smoke, haze, fog, they all make things appear farther away than actual. This can be very dangerous if you're flying near kind of high or rising terrain. This happens to people in Truckee a lot, is they'll get kind of in these CFIT situations, controlled flight into terrain, because their perception is very off of that rising terrain around them or the terrain around them in general because of some type of reduced visibility, and unfortunately have a controlled flight into terrain situation. So when you're viewing through reduced visibility, specifically fog, haze, and smoke, you want to use slant range viewing. And what that means is you're going to be viewing at a slant. You're not going to view straight down. You're not going to view straight ahead. You're going to kind of look at a slant, and that gives you a better perception through that reduced visibility. But really with any visual illusion, the biggest thing is, and honestly, with all of these, the biggest takeaway is to know the symptoms, know the signs, know how they occur, and know how to treat them. Just like with visual illusions, these are more benign visual illusions. When you get into the IFR ones, they can get pretty scary. But knowing how they result and then knowing how to put a stop to them is extremely important, just to kind of not end up in this situation. I actually think I have that on the next page here. Yeah. So the takeaways are, to take care of yourself. because anything to do with aeromedical factors, whether it's hypoxia or stress or visual illusions, or the inner ear or anything, it all has to do with your health, right? And how you're taking care of yourself and your body. Like have a good relationship with your body and know when it's talking to you because it absolutely will. And then listen to it, know your symptoms, know what you feel like when you feel hypoxia, know your limits when it comes to flying with potentially, a congested sinus system. Know, if you are more prone to visual illusions or spatial disorientation. And then know the treatments, if you find yourself, hopefully not, but if you find yourself in one of those situations, know how to get out of it. The biggest thing that people say that I really respect is like we fall back on our training, right, in times of emergency. And so if you know these things by heart and you have a good understanding of your health and your body and how you are going to react to these different things, you're going to be able to treat yourself and make it out to the other side of that. And then be proactive, which is just kind of what I've been preaching this whole time. Is just don't find yourself in that situation to begin with, because if you know, you can anticipate, then you're never going to have to be in that situation and you're not going to have to worry. So, um, I hope that for the things we talked about, it gave you a good idea. Again, aeromedical factors is somewhat of a hefty topic. Like, honestly, 2 separate ground sessions for this is kind of, I would say, typically what I do with my in-person students. But there is a lot of very helpful information out there. Like the FAA is super up on it when it comes to aeromedical factors. So you can look on their website or Chapter 17 of the Pilot's Handbook of Aeronautical Knowledge. It's about 32 pages, and I think it's very comprehensive information if you're interested in more of this. But otherwise, I want to open the floor to you all if you have any questions or any comments. I'd love any feedback if you have any as far as like the teaching, the presentation.
Have any of these things happened to you that you've noticed and maybe you've had to adjust? Yeah.
Yeah, thank you for the question. So the only thing that's really happened to me, very thankfully, I have not, experienced hypoxia, or any visual illusions, but I have experienced congestion actually during my instrument check ride. I was feeling a little bit like I had some allergies, and as we know, you cannot take allergy medication as a pilot because most of them are also antihistamines, which are drowsiness medication. So I said, well, I'm not going to reschedule my check ride. I'm just going to go do it. Which, I'm glad that I did ultimately because we also didn't go very high in elevation, but I definitely felt that, that trapped gas on the descent because, we went around 4,500 for the instrument check ride, which isn't too high as far as altitude goes. And I felt fine on the way up, but on the way down, definitely a noticeable difference in that pressure in the head, pressure in the nose, pressure in the lungs. And, you just really come to realize like, wow, my sinuses, my inner ear, they're very sensitive. And you don't really realize that until, your body won't equalize.
Wow, that's a lot for an instrument checker. I don't know if I would have survived, but good for you for getting through it.
Thank you. Yeah, it was it was a lot, but we lived.
Oh, when will you be teaching this course again, in person, or when will you be teaching this course? I guess in more depth or in a second part.
That's a great question. I'm not honestly sure with you. So at this point, I don't do any of the Girls Love to Fly grounds in person. When I was speaking about the in-person grounds, I meant for my individual students, at like Mach 5. But, as far as a secondary part to this, I could absolutely reach out to like Jamie and the crew and see if they'd be interested in doing a like part 2. But as far as now, I don't have anything lined up necessarily.
And what's the name of the the Air Force base that has the simulation, or do you know like of a Navy base that does the same thing, or?
I'll be honest with you, I'm not super familiar with the Navy or Navy bases. However, I do believe that there is a like master list of all the places that do that simulated hypoxia testing. So if you kind of look up like FAA simulated hypoxia, it should give you kind of a directory. But the local one here is Beale. So it's Beale, Beale Air Force. And they're up near like Marysville, Yuba County area, if you're familiar with that.
Thank you so much.
Of course.
I just want to say, I think I really liked the examples that you gave and some of you gave little extra bits of information that I thought was really helpful. I'm trying to think, like my notes from earlier, but some of the ways that you explain stuff, like really kind of like, because I've heard some of the stuff before, but it kind of like brought it back to my mind very quickly, or I was like, oh, this is like going to be a great way to remember. So yeah, thanks for doing this. And I think you did a wonderful job as just a student. So thanks.
Oh, well, thank you very much. That means a lot to me. And I really appreciate you all being a captive and engaging audience. And also, if you would like, you can absolutely reach out to me at any point, either through Girls Love to Fly or, if anyone has any further questions, I can definitely give you my phone number. But yeah, thank you guys so much. I really appreciate it. And I hope that you all have a great rest of your night.
Thank you. Really
Yeah,
appreciate
Thank
thank
you.
you.